So again, first, I will properly introduce myself. My name is Samah Yahya, and I'll be the moderator of this session. And the capacity is I am the education coordinator. So I run these sessions every single month on different topics surrounding sickle cell disease. And today, like I mentioned before, we'll be taking a deep dive into pain assessment and management with Dr. Marko Erak. Please note that this session will be recorded, and for all those who attend and would like to look back, or for those who couldn't make it, this session will be available on Skego's website at www.sicklecellanemia.ca. Again, this session does not, information shared during this session does not constitute medical advice. So keep that in mind as we go throughout the majority of this presentation today. And we'll quickly go through some rules of engagement, but before that, we'll start with a land acknowledgement. Currently, I am in Hamilton, and wherever you are, just make sure to reflect on the land that you are. I am personally on, and I recognize that I am on the land of the traditional Mississauga and Haudenosaunee Nation within the land protected by the Dish with One Spoon Wampum Agreement. And as you sit here today, just make sure to reflect that the land you're in and how it's come to be ours today. Again, housekeeping for rules of engagement. Please make sure that you are on mute at all times and during the duration of the presentation, and we'll go over how the Q&A session will be moderated later on. Again, hold your questions until the end of the presentation. We have a time at the end reserved for Q&A. In addition to this, give me a second, you can however, use your questions during the chat method, just located at the bottom of the screen. So if that's one way you'd like to put your question out there, please be sure. Our presenters today are Dr. Marko Erak, deserves to speak without being interrupted by audio feedback or any other things. So just be sure you listen to the sound that you are making throughout the session today. We want to also make sure that we are using respectful and appropriate language here, as well as only posting or talking about situations in which are appropriate and related to today's discussion topic. With that being said, I'll now jump into the rest of the presentation, and I'll start off by introducing our speaker today, Dr. Marko Erak. Dr. Erak is a practicing emergency room physician, and he completed his medical family medicine training at McMaster in Hamilton and finished additional emergency medicine residency training at the University of Ottawa. He's been practicing for the last 7 years at Humber River Hospital, where he's also a physician lead for the ED group in simulation training and continuing medical education. He has an interest in medical education and ED process and flow improvements, and he has been involved with Skego since 2021. With that being said, we will now jump into our presentation today. So without further ado, I'll introduce Dr. Marko Erak.
Thank you very much. Okay, so hi everyone. Quite a nice introduction. It's been a pleasure to work with Skego. We sort of crossed paths serendipitously in 2021, where Sickle came and gave a talk at Humber, and ever since then we've been in a mutually beneficial, from a point of view of learning, relationship in terms of both what I've learned as a practitioner, and that is what I'm going to share with you today in this talk. So this talk I've been asked to give is on pain assessment and management in the pediatric and adult population. Frankly, this talk could probably be hours long, but I've tried to distill it down specifically to just that, managing pain. And I'll get to what I mean by that. This is a difficult topic because this is a source of quite a bit of morbidity. So quite a bit of pain and suffering in patients presenting with sickle cell disease to emergency rooms throughout the country. I'll start first with, if it lets me, come on, there you go. Just a quick declaration of my conflict of interest. So I really don't have any financial conflicts to declare. The two sort of biases or things to know about me is one, I work as a community physician in the emergency room. As you know, UHN probably has a much larger foothold in the adult world for sickle cell disease, and SickKids, the hospital for SickKids, has a much larger foothold than we do in the treatment of sickle cell disease in the pediatric population. However, Humber River Hospital is situated right in the middle of Toronto, so 401 in Keele. And we see 800,000 people, or we have a catchment of 800,000 people that we're responsible for. And quite a lot of populations near us suffer from sickle cell disease. So we're positioned to treat the patients when they come in crises, which is why this is relevant from the point of view of this talk. And the second bias I'd give is, probably prior to my work with SCAGO or the relationship with SCAGO, I probably treated sickle cell pain very similarly to the way most people treat it. It's a busy emergency room. Someone's showing up with extremity pain. And the thought is, well, it's just leg pain, hang tight, we'll treat you, what's all the fuss about? So that was my bias going in. But as we will see, there's more to the pain than just saying it's just leg pain. So I'll give you an outline. This talk was made on purpose so that it can be given in a forum like this, but also so I can give it in a forum to, say, students or colleagues. So it's, oh, somebody's not mute. Can you hear me? Can you hear me? Yeah, okay, it's something was disconnected. Okay. So this will be like a mini medical school in terms of what I'll present when I talk about pain. But then, and we'll talk about, that's what the pathophysiology of the pain is. I'll quickly mention sickle cell disease and vaso-occlusive crises from a medical point of view, because it's important to understand that in order to understand why we're treating and how we're treating it from a pain point of view. Then we'll talk about the assessment of pain, specifically in an emergency room. That's my expertise, but that's also where individuals with crises will present. Then I'll go into different ways we can treat the pain. And then sprinkled throughout, let me see, where's my, and you'll see this little sign. There will be barriers to the treatment of pain. Ultimately, that's the biggest issue here. It's a push and pull. There is pain that needs to be treated well, and there are barriers to us treating the pain well, even though we know how. So I'll quickly go into pathophysiology of pain. So what's the science behind how pain occurs? Well, the bottom line is it's very complicated. There's an entire specialty devoted to this, and you can probably spend weeks in seminars discussing how pain is formed. I'm distilling it down to sort of a binary way of looking at it. So two ways of looking at it that is very simplistic. There are multiple theories of how pain is interpreted, but this simplistic view helps guide how we would treat the pain. And the simplistic view is this: pain can sort of be split into two types. One is the nociceptive pain, which we'll talk about here. That's basically a quote unquote good pain. It's a evolutionary pain that was developed in our body to tell us, hey, something's in danger, something's hurting, you should probably change what you're doing. That's this pathway here. The other pathway is a neuropathic pain pathway. That's usually more pathological, meaning that's usually there's some injury to nerves somewhere. And as a result, you develop this nerve-like pain. And although this is super simplified, long-term exposure to nociceptive pain can lead to neuropathic pain. And that's sort of how a pathway from acute to chronic occurs. It's way more complicated, but that's the gist. And really, individuals with neuropathic pain have this gnawing pain. They're more sensitive to pain. They can feel pain to substances that don't induce pain. And the reason this is relevant to sickle cell disease is because usually in the first 2 to 3 decades of life, this is the kind of pain patients or individuals face. Later on in their 3rd, 4th, 5th decade of life, the longer they've lived with pain from sickle cell disease, it develops into this neuropathic pain. And that's relevant because this is relatively easier to treat in an acute basis than the neuropathic pain. So I'll focus on, we'll kind of get a little fancy with the science here, but this actually is relevant to how we treat it. When you look at nociceptive pain, there's sort of 4 or 5 different, give me a second. Different things you need to worry about, or the 4 or 5 different steps or stages of how the pain gets registered. So the first one is something causes pain somewhere, and you have these things called nociceptors, which are endings at the nerves that you can think of it as a modem. So you're taking one type of information, which is the pain. So something physical, chemical, burning. So it's usually temperature related, or it could be related to the acidity in the area. Anyways, it translates that into a nerve message. Now that gets transmitted to sort of what's called a dorsal root ganglia, or the back of your spine, and that gets relayed from your nervous system is divided into 2 areas. One is the peripheral, which is out here, and then the other one is the central, which is your brain. There's a lot of the processing. So that gets relayed to the central, and then it goes up what's called the spinothalamic tract to the brain, and it gets integrated, interpreted. And all these areas, what they do, the outer areas, the cortex, relate the pain to where it is in your body. But you have processes in your brain that are related to memory, that are related to mood and feeling. So all of these get integrated into how the pain is interpreted. And based on how that gets interpreted, the pain can the pathway goes down to modulate. So this is why different individuals will have different tolerances to pain, right? If you're in a good headspace, you've got good supports, you've got good coping mechanisms, then the interpretation of the pain, the same stimulus, will result in you modulating. You actually cause the body to relay less pain signals forward. But if you're in a bad headspace, poor social supports, you're depressed, poor coping mechanisms, then whatever pain you're experiencing can actually get upmodulated. So, which means you're feeling that pain even worse. So this is all relevant, especially for sickle cell and how it's managed both at home and in the hospital. Now, this is relevant from the point of view of how we treat it acutely. So NSAIDs are things like ibuprofen or Motrin. These type of medications are great. They work on something called prostaglandins, and they really work well at the original relay of the message. And that's why they're often first line, and they're used over the counter in treatment of any pain. The other thing that people are quite familiar with are medications called acetaminophen, so Tylenol, or paracetamol in Europe, which is unfortunate. Even Europe has an IV form of paracetamol, which actually works really well. But that works at more of a central level. It's more of a black box. It might be something to do with something called peroxidases, but point is it works more in the brain level and how you interpret the pain. And sometimes people say Tylenol doesn't work. Well, it probably doesn't work because this is just outside of sickle cell. It probably doesn't work because either you're not taking a big enough dose, or you're just taking Tylenol alone. You take these 2 together, you can get quite a good pain relief. The mainstay, or sort of the workhorse in the emergency room and in hospital for patients with sickle cell are opiates. So things like morphine, hydromorphone, fentanyl. And you can see, just based on where it works, why we use them. I mean, this is a very effective pain medicine. It works on multiple levels in terms of having the pain message relay to your brain, and then how it's modulated as well. It has its side effects, which we'll talk about. And then finally, I'm going to mention another medication that's being studied more and more. In the research world of emergency medicine, there are often fads. We're now in the ketamine fad. Ketamine is finding purposes in all sorts of things, from depression to pain management. And ketamine can also work hand in hand with all these other medications to relieve pain. And what you see here, when you hear, or when doctors hear, anyways, something called multimodal pain management, it means you're treating the pain with multiple different medications.
It's that intake, and so it is going to contribute to cancer of the stomach.
That's okay. It's all right. Multimodal pain management is basically saying that it's multiple ways of treating the pain at multiple levels of how the pain is interpreted. So that's pain in a nutshell. I just distilled probably 4 years of school in 5 minutes. But this is relevant because pain in sickle cell disease is still pain, but there are nuances to it, and there are reasons why we need to look at how we're treating it. First of all, let's look at sickle cell disease. Probably to this group, I don't need to go into the minutia of it. You know what sickle cell disease is, and for some of you, you probably live with it as well. But as an overview, it's a genetic disorder of the hemoglobin molecule. The hemoglobin molecule has 2 alpha chains, 2 beta chains. This is a problem in the beta chain. And why that's relevant is because the hemoglobin molecule is the one that carries your oxygen in your red blood cells, which at the end of the day, all of our biological processes need oxygen. Sickle cell disease, it's inherited. It's a recessive trait, predominantly in individuals of African descent, but the genes are found in Arabic, Indian, Hispanic, and Mediterranean backgrounds as well. And essentially what happens is your normal hemoglobin molecule, which looks all nice and folded the way it's supposed to be, it becomes abnormal. It becomes a hemoglobin S molecule. And there are variants. There's sickle cell SS, SC, S beta thalassemia. All of them predispose the individual to sickling, which is where the name comes from. And all that is, it means when the body or when the blood cell or when the red blood cells are exposed to some sort of stress and become deoxygenated, the blood cell sickles. It forms these abnormal shapes. So normally, blood will flow very nicely and squeeze its way through the different capillaries in our body. But when it sickles up, it blocks off the arteries and prevents blood flow. And this is what's meant by vaso-occlusive crisis. Vaso means vein, occlusive means blocked. So blocked vein. And you can imagine vaso-occlusive crises can happen essentially anywhere because you have veins essentially, or you have vessels. It's arteries and capillaries everywhere. And when they occlude and it becomes sticky, you're causing blood not to flow to these areas. And this is what I'm trying to show here. I mean, vaso-occlusive crises or the pain crises, the pain can occur anywhere. One thing to know in the realm of medicine, in terms of, there's this concept called pain out of proportion. And it relates to what's called vascular or blood-related pain. One of the most painful pain, and this is recognized, one of the most painful pains you can experience is pain due to lack of blood flow. So individuals that have ischemic limbs, so they have a clot that goes into their leg, it cuts off circulation to their leg. They have what's called pain out of proportion. Leg looks not too bad. They're yelling, they're screaming, they're in a lot of pain. Individuals that have blood cut off to, let's say, their abdomen, there's this thing called ischemic gut. These are individuals who have a lot of pain in their abdomen, and it doesn't exactly fit the exam you're seeing. It's called pain out of proportion. So we recognize that vascular pain is probably the most painful pain you can experience. And yet there's this disconnect in sickle cell disease, and we'll get to that. All I'm introducing here is because, again, I'm going to focus on pain, predominantly in pain management. However, when someone presents to pain, one thing we need to do, one thing the healthcare system needs to do, and most places do this well, is you need to still recognize that this could be more than just, pain, like a pain crisis. You could have what's called avascular necrosis, or the bone dying of the hip. You can have an MI, a heart attack. You could be having an acute chest crisis, or infarcts in the lungs. And I mean, these are life-threatening things. You need to make sure there isn't a stroke, that there isn't issues with retinal ischemia, that you're not causing what's called end organ damage, or damage to your kidneys, your liver, important organs. And in the pediatric population, you need to make sure that this child isn't experiencing splenic sequestration, right? So although pain is going to be the number one thing we talk about, while patients are worked up, you still need to make sure that there isn't something else on top of that that's going on. And this is also relevant because if there is something else going on, let's say somebody's having an acute chest crisis, we tend to have it's not necessarily, it is a bias. We tend to have a bias where you would treat the medical thing, the organ threatening thing first. You would get fluids, antibiotics, monitor the person, and pain somehow just makes its way lower down the list, which isn't the way we should do things. And that's why one of the barriers to good sickle cell pain control is the fact that vaso-occlusive crises can manifest in multiple different ways. It would be a lot easier if every time a patient with a vaso-occlusive crisis shows up like this, then from a cognitive, intuitive point of view from the treatment group, it's a lot easier to say, oh, this clearly looks like a vaso-occlusive crisis, so we'll follow this algorithm. Fact of the matter is, patients can show up with musculoskeletal pain, arm pain, leg pain, hip pain, but they may not necessarily. So this certainly is a barrier to that. And like I mentioned, if they do show up with both, a pain crisis, but also an issue in one of their end organs, like an acute chest crisis, pain tends to take a backseat to treating the, quote unquote medical abnormality, although they both go in hand. So I'll mention a few more things. I talked about this. Acute pain crisis is usually down the nociceptive pain pathway, and it can develop into chronic pain later in life. Triggers can be anything. It's basically a stress on the body. And I've listed a few things like, fever, dehydration, any sort of illness, or any acute surgery. I'll mention hydroxyurea a few times, but the purpose of this talk isn't necessarily hydroxyurea. It has a role in preventing painful crises, making them less frequent, less painful. It has a mortality benefit as well. But again, that's part of the overall management of the patient. And like I said, in acute pain crises, it's our job to still rule out anything else that's going on. And actually, 2 weeks ago, this is a great example. There was an individual who showed up at our hospital who had abdominal pain. And he showed up in our sort of walk-in clinic area, and the physician there wasn't comfortable having an individual with sickle cell with a pain crisis in that area because of the pain medication that would need to be given. I quickly saw him, and the assessment's really quick. You ask the patient, does this feel like your pain crisis? And he clearly told me, no, like this is definitely nothing like that. This is something in my stomach. And it turned out it was a gallbladder issue for him. So just because a patient with sickle cell has pain doesn't mean it's sickle cell. And again, that can affect the way the patients are treated in any sort of way. This here comes from the clinical book from Ontario, like the Ontario Guide for Sickle Cell. We don't need to go into details of it. All this does, and this is probably a conceptual change for a lot of practitioners that treat sickle cell, is the fact that a sickle cell, so you break an ankle, you twist an ankle, you're going to have your maximal pain probably right after the event, or maybe a day later, and then the pain sort of goes down as healing occurs. Sickle cell is a bit different. Sickle cell, or at least a crisis anyways, it needs to be conceptualized as a longer term event, and that's what this chart does. So an individual might be in a steady state, meaning they're like their usual self, there's no big issue, and then some sort of trigger happens, and probably over the next day or two, their pain, wherever it is, will start to increase. This is usually the level, and these are arbitrary numbers, by the way, but this is usually the level where people will try to do their coping strategies, will try and self-medicate at home. They'll do whatever they can to try and manage the pain the best they can. Sometimes, the pain will go down and they feel better, but when they're presenting to the emergency room, it means that they've passed the threshold where the pain just isn't being treated well or managed at home. So that's why usually where they present into an acute setting, a hospital. And the difficulty there is that there's an established phase. Once we get to this established phase, if we haven't been able to break through the pain well enough, once they're in an established phase, the patient, can have pain for days, if not a week at a time, until all the processes of inflammation, whatever needs to happen, resolve, and then they finally get resolution of pain. And this is probably also the difficulty with treating patients with sickle cell related pain, because the pain crises can last longer than what you would expect for a typical quote unquote pain episode. So this also explains why there's sometimes a mismatch of the suffering a patient would experience and the expectations a healthcare provider might have of how the pain should react. And we'll talk about that. So we'll get into this. I want you to know how we assess pain when somebody shows up to assess pain, and what the difficulties are specifically in a sickle cell disease population. This is a very common thing, or a very common tool that's used in pain management. It's called the visual analog scale. And it can be just a line. It can be from 0 to 100. It can be these faces. You would ask a patient to rate their pain on a scale of 0 to 10, where 0 is no pain, 10 is the worst pain possible. And then you would use this to sort of gauge how aggressively you treat someone and how you would you retreat ongoing pain. The faces here are in cases where there may be a language barrier or a person may not understand the 0 to 10 tool. It's sort of, well, how does the patient look? You can kind of gauge what number they are. This is a great tool in research. And I will say, even the guidelines for sickle cell disease do say to use a tool like this for monitoring progression of pain management, but there are issues with it. The issues are this, according to that tool, and probably according to most of the biases of an individual treating pain, you would expect this person to be in pain. He's hunched over, he's clenching his chest. If this man tells you he has pain, you're poised to believe him. The problem is, and I alluded to this before, and we'll talk about it a bit later, is that patients with sickle cell disease, pain is sort of a passenger in their journey of life, right? It's someone they've gotten to know. So they may be managing pain at home their own way, which means they often more times than not look like this. So this individual probably has a 9 or 10 out of 10 pain if they're showing up to your emergency room. But they're there, their eyes are closed, they're sort of zoning out, they're doing their thing. So from if you use that tool and from the foot of the bed, you'd say, well, how could you be 9 out of 10 pain? You look fine. But what you don't know what's going on behind is this individual might be meditating, they may be praying, or like this individual here, they may have other coping strategies, warm blanket, music, and there's another bias here. She's quite emotional, so maybe your pain's not 10 out of 10. You're just emotional. Calm down. You'll be fine. Like we'll give you some Tylenol. So there is a bias here where the expectation is that somebody in pain would look one certain way, but the fact of the matter is more times than not, patients with sickle cell look any sort of way. Frankly, like the point is this is the sort of textbook view of how things should look, but we need to get out of that. So it can't be just textbook. And the other problem is the squeaky wheel gets the grease. In a busy emergency room where people are stretched thin between multiple patients, if someone's yelling and screaming, even though that's not an appropriate way to get attention, and I'm not talking about sickle cell, I was saying anyone, you're more likely to have staff divert their attention to them. So this is why a lot of silent suffering occurs. And this is why some of the guidelines discuss timeliness to pain management. So this is the other barrier to good pain control. There's de facto impression of pain. So there's an expectation of how pain should look, and then there's a reality of how it does look. Which is why, at least for the decision of how to treat pain, I would advocate not really following, at least don't follow what they look like. You could you still should use a tool, and the guidelines say to use a tool because it will give you an idea. If they tell you it's 8 and you give them pain medication 2-3 times, if they're still telling you an 8, then it's inadequate. But if their pain is at 8 and then 4 hours later after repeat doses of medication they're down to 4, you're going in the right direction. So there is some guidance there. And this is sort of what I alluded to earlier. The actual experience of pain in patients with sickle cell, and also the interaction of healthcare with individuals with sickle cell disease who experience pain, it can be analogous to an iceberg. The majority of patients are silent sufferers. They are managing their pain at home the best they can. It's this tip that's showing up to healthcare that we see. And frankly, that alone tells you that the pain is, it's at least an 8 or a 9 out of 10. It means that these individuals up here have tried this for as best as they could. And despite that are showing up to healthcare to get pain management. So I really don't care what the number is. Your number could be 6 or 8 or 10. Fact of the matter is the fact that you're showing up, it means that you're suffering with the pain. And I think that's more of the conceptual shift that we as healthcare workers should have. So oftentimes the way pain the way I would assess the pain is I would simply ask the patient, how bad is the pain? Is it similar to your previous episodes? What usually works, that sort of stuff. And that's actually institutionalized in the, or that's sort of standardized in the guidelines. So the clinical handbook for sickle cell disease vaso-occlusive crises from the ministry in Ontario talks about timely pain management and what you should do in your assessment of the pain. Highest recommendation in their entire guidelines that they have is that anyone with a vaso-occlusive crisis should be rated a CTAS 2. So that's their level of how sick someone is. 1 is someone actively dying. 2 is someone with a very serious disease. So the patient should be labeled as a serious disease. And they should be treated with opioids, strong pain medication within 30 minutes of arrival. That is the target. The other things as a part of your assessment, is what I talked about, is asking, nowhere here does it say, what's your pain out of 10? They talk about intensity, but they focus on all these other things. Is it similar to your previous pain? Does it feel like your usual sickle cell pain? Did you take anything at home? Do you take anything usually at home? So it's to get a sense of where they are in their experience of pain and how they're treating it. Now, I talked about, the barrier here, which is that vaso-occlusive crises can mimic other things and other things can present with vaso-occlusive crises. And that's all the guidelines are saying. You need to make sure there's nothing else going on. And then finally, it's talking about acknowledging the pain and treating the pain in a multimodal way. So not just with medication, but also with the physical space. And we'll talk about the 3 Ps of pain management later on. The only other thing that's relevant to pediatric population as well is, not forgetting to palpate the abdomen, look for a large spleen for the younger population that still has their spleen intact. So how do we treat the pain? So I'm going to go through this quickly, but I presented you this. There are different medications we can use, and I'll just introduce them to you and talk about some side effects. A few things like inhaled nitric oxide, corticosteroids, and magnesium sulfate have been studied. They don't really have a role or really work in the acute pain crises. Like I also mentioned, hydroxyurea. We have a good amount of experience, decades worth of experience with this. The bottom line is there's a type of hemoglobin called fetal hemoglobin, which we have when we're in utero in our moms, and there's still a small amount afterwards. This is less prone to sickling and to the crises, and hydroxyurea increases the amount of this type of hemoglobin in our bodies. It's meant for more preventing crises and long-term management. And then there are studies, that's all I put here. So we've got good experience with it, and it's shown to be beneficial even in the younger population. But really, this is the crux of the talk. So this is the meat of the talk. The management of sickle cell disease can be sort of distilled down. And if you look at the Canadian Hematology Association guidelines, the 3 Ps of pain. So it's the physical, the psychological, the pharmacological. Pharmacological one is the one that is the most technical, but all 3 are equally important. The non-pharmacological things to think about are either distraction techniques or techniques that allow an individual to have support. So allowing visitors or supportive family, allowing them to distract themselves with any sort of technology that they need or social media. So again, this is a bias. You see someone who's telling you they have 9 out of 10 pain, but they're on Facebook or on Instagram when you walk into the room. Again, the disconnect, this comes unfortunately because there is an abuse of the how would I put this? There's an abuse of stating you're in pain for nefarious reasons in other illnesses. But in sickle cell on its own, this is actually part of the management. And that's unfortunately where the disconnect comes. But, some sort of distraction, giving a warm blanket or warm place, not placing the patient in a windy, drafty hallway, regardless of how busy you are, meditation, music, video games for kids. These are the non-pharmacological pain strategies that individuals may undertake at home, but this should continue when they come to a hospital. And there's sort of a link of other things that patients would do at home that when they work together are very helpful. And this includes good social supports, easy access to their own healthcare teams. So they don't necessarily need to come into a hospital if they need more pain medication. Having a good plan for prescription medication and ability to renew it, having good access to over-the-counter medications. And you can see from a socioeconomic point of view, some of these things are limited to individuals who experience poverty, right? Your ability to go in and out of an office if it's across town, depending on where you live, the ability to pay for medications or pay for renewals will certainly affect your ability to control your pain. But in other things we talked about, the hydroxyurea, non-pharmacological things, distraction techniques, and social supports. And again, here, individuals who have poor social supports, either poor connection with family, with their community, they have a higher risk of experiencing pain crises more often and more intensely. And again, the whole point here is, when this is working, this is why these patients show up to us like this. So, they're doing all of these things and it is working. However, despite the best efforts of the patient, this is a real crisis. That's why they're presenting to us. They still present, but this helps a healthcare practitioner understand why a patient may look one way or another, not the way we expect them to look for pain when someone's in pain. And this I had on an earlier slide. Again, even the clinical handbook of sickle cell disease, vaso-occlusive crises, talks about these 3 Ps or other modalities to treat pain. But this is sort of why I went to school, so I can give the pharmacological treatments. So I'll talk about that. Kidding aside, though, this is sort of when you talk about pain management to a healthcare provider, this is where their mind goes to right away. And I'll go through the 4 different treatment categories and let you know just how we use them or why we'd use them. So anti-inflammatories, we talked about, so things like ibuprofen or naproxen. They're oral for the most part. They're usually a part of an outpatient management, and they often get forgotten. We sometimes go straight to opiates and we forget these, but again, as part of multimodal, these are important. The issue with these are great in younger individuals. In older individuals, the risk of stomach ulcers, kidney issues, heart issues increase, which limits the ability of us to use these. And if somebody's on a blood thinner for whatever reason, we're also limited to use this. Ketorolac is one that we can give in the IV if for whatever reason the patient is vomiting or can't tolerate oral. Acetaminophen, it's only available in oral formation in North America. The reason I bring this up is acetaminophen is great. It's the issue is acutely can be toxic. So if somebody takes too much acetaminophen, it can actually affect their liver. And there are a lot of over-the-counter things that someone may use for other reasons that also contain Tylenol, or acetaminophen. So we sometimes just need to be careful in terms of what a patient is taking. Opiates. This is probably the workhorse of pain management. The 3 opiates that I'll really talk about are fentanyl, morphine, and hydromorphone. Those are the 3 right here. And they are probably the ones that we are the most comfortable with in the emergency room and that we can give through the IV. And the only reason you would choose IV over oral, it really comes down to onset of action. So someone who's in a real bad pain crisis, fentanyl is a great drug because it comes on within seconds. This is a medication we use in the operating room for really bad pain when somebody has a broken ankle and we just set it. It comes on real quick and it doesn't last long either. So a lot of the side effects of opiates are the fact that someone may get nauseous or vomit, that their respiratory rate goes down, so they may slow down their breathing, or if you give too much of a dose, they may stop breathing. So that can be life-threatening. And that's probably the biggest barrier to just giving opioids right away in a busy emergency room to someone who presents with pain. And this is any pain, is that there's a hesitancy to give medications that could affect your breathing without having someone in what's called a monitored setting so that we can keep an eye on you. And when the emergency room is busy and packed, you're less likely to find these spots. So there's a discomfort just from nursing and physician point of view of giving high doses. The reality is, though, the ceiling dose or the peak dose that you can give to someone really varies on them. Opioids work on these receptors called mu receptors. Oh, and my mouse is going all crazy. There. Okay, sorry. Mu receptors. There are other receptors, but these are the pain ones. And the amount of receptors you have can be up or down modulated depending on how much opiates you're exposed to. So I mean, that's also the pathway of addiction, but it's also not necessarily addiction. So point is these medications work really well, but their side effects are what sort of make individuals hesitate. The usual dosing, let's say for morphine and hydromorphone, would be like 2 to 10 milligrams for morphine, 0.5 to 2 milligrams for hydromorphone. This is what most practitioners are comfortable with. The issue, if I recall the last 3 or 4 patients with pain crises that I had with sickle cell disease, they're needing 6 or 8 milligrams of hydromorphone, which is 40 milligrams of morphine IV at a time, and even then, you're redosing almost every hour, and those are uncomfortable doses for most practitioners because you give an opioid naive or an individual who hasn't had opioids before that high of a dose, you'll stop their breathing. But again, this is where that conversation back and forth between you and the patient needs to occur, because why did I give the dose? I gave the dose because I asked the patient what worked before. That's the dose they gave me. And this is where these practice plans come in for sickle cell disease in areas that really treat it well. This is just to show that all the opioids are essentially the same. So you can have one dose of one and change it into another dose of another. So it's not like one is better than the other necessarily, but it's just someone may have a preference over one or the other. Yes, so then this leads to the big concern around opiates, which is this concern about addiction. And the concern about addiction is sort of like, is entangled with, what I mentioned before, which is a knowledge and comfort with opiates. We have a certain knowledge and a certain comfort. And when we're getting to these bigger doses, are we causing the patient to be addicted? Are we causing harm to the patient? So it's sort of this seesaw. So in the concern of not causing harm from the medication, we're causing harm by not treating the pain, unfortunately. I'll get into the research about both of these later on. The last medication I'll talk about, which is sort of up and coming, is this medication ketamine. We use it a lot for sedating patients, for treating pain, for treating agitation. It's great. And I bring these 2 papers because, again, this group here, it works out of McMaster and Hamilton, Mark Crowther and Gordon Guy. So like there's a Canadian flair to the research as well. And they've shown that ketamine can be helpful in vaso-occlusive crisis. The reason ketamine is great is because you don't stop breathing. So you don't have that same problem with as opiates. The only issue is in older individuals, you could get an emergence reaction, which means they can sort of hallucinate or have trips once they wake up. And in the younger populations, they're higher risk of salivating a lot or becoming very, just having a lot of salivation. And nausea and vomiting is a risk too. I'm almost done. So I'm going to talk about the barriers more in detail. So that's how you treat it. Fact is, we know how to treat it. We can treat it. And when it's treated well, that's great. But there are these barriers that get in the way. And I've chosen these 3. I mean, there are more because they're nicely summarized in research out there, which is that manifestation of vaso-occlusive crises, the impression of pain, and the concern about addiction. And the impression of pain as well really kind of ties into the socio-cultural factors affecting pain. That's sort of how they talked about it in the article. So we talked about this in terms of the manifestations. So I don't need to go into more details, but I wanted to present this again. This is out of the handbook. Shared lived experiences that patient are mentioning, and it sort of ties into this. There's a visual disconnect, and unfortunately, this is a bias of the way Emerge works. If you're not bleeding or broken, if there isn't something actively squirting, and you look comfortable because you're using your own techniques, there's a disconnect of how aggressive we need to treat your pain. And this one stood out to me, because we say this a lot, ED is for emergencies, and, the patient recall as well. If this is an emergency, that's why I'm here. So this is unfortunately like a common lived experience too. And then, it's like, yes, I look this way, but you cannot see my pain. So these are sort of powerful excerpts from the handbook worth sharing. The impression of pain or the socioeconomic issues of pain come down to the fact that, how do people perceive, or how do healthcare providers perceive pain? And there have been a lot of studies looking at how do individuals perceive pain, especially in sickle cell patients. Out of Saudi Arabia, this is a survey that looked at it, and the attitudes tend to be more negative, especially in the adult population, more in the pediatric population of patients presenting recurrently for sickle cell related pain. There's thought that the individuals are drug seeking. In terms of, there was a study that looked at different barriers, and for the most part, it found, if the practitioners had negative, if they had poor provider knowledge of how to treat the pain and sickle cell related pain, the management of the pain would be poor as well. This one here found that the lower your attitude or the more negative your attitude towards sickle cell disease related pain, the less likely you are to know the guidelines related to it and the less likely you are to provide good care. And then this one in the pediatric population found that younger learners or younger doctors that are going through their training process have more negative views and are more likely to view individuals that are showing up again as drug seeking. The one positive outline of this article was that they found that as the doctors trained, their views became less negative. So that tells you that there's a role for education in terms of changing attitudes. Sickle cell disease patients can often be described as frustrating by providers, and that's noted in the literature too. And that sort of adds to the negative attitude, which leads to negative negative outcomes in terms of how the pain is treated. This one I put in here too. This is more for me, the priority of pain management. Unfortunately, when you're juggling multiple things, it's not uncommon for the priority to treat pain in a department. You have to treat your sepsis, you have to treat your heart attack and this and that. So pain management sometimes can fall off the radar. And that's part of the impression and the bias. And then there's this discomfort. It's what I talked about. There's an opioid phobia. One, there's a worry of addiction, which we talked about, but frankly, there's just a fear. And this was, again, not too long ago, a colleague of mine was treating a patient who he ended up in a meeting. And I think the patient was asking for a higher dose. And he just said, well, I just don't give those doses. And no amount of convincing him would convince him to give a higher dose. It's just, no, I give 2 milligrams. And if you need more, somebody else can deal with it, which is unfortunate. And obviously addiction and drug seeking behavior play a role in this. Bottom line is individuals with sickle cell disease do not get addicted at any higher rates than the general population. In fact, there's some evidence shows that it might be even lower. And then, I mean, you can't give this talk without staring truth in the face. Fact of the matter is, this is a disease of racialized individuals, and there is either conscious or unconscious, but there is an element of racism, and it can be a small element or a large element, but it's there. This is interesting. So when you look at, and I'll share another story of how, racism can play a role in healthcare. When you look at how we describe chest pain for heart attacks, a lot of the studies were done with, white Mormons out of Ohio. So the typical presentation of heart attack chest pain is this crushing elephant on your chest that's worse with activity, goes away with rest. Fact of the matter is, in racialized individuals, in women, in older individuals, that's not how they present with a heart attack. So probably the last 20, 30 years, we've gotten better at recognizing atypical presentations of heart attacks. But for a good, several decades, that sort of racist outlook really harmed people just in the heart attack world. Now, you bring this over to sickle cell disease. The fact of the matter is probably the lack of, aggressive evidence out there is probably led to, not probably, but is led by racist biases. I mentioned these socioeconomic biases. If you're more poor, it's harder to access all these resources. You may be further away from a center that knows, your sickle cell. You may have to travel more. You may be more hesitant to actually go seek out help. The other sociocultural barrier here is the fact that, if you're having recurrent pain episodes, you're having frequent visits, you're more likely to be labeled, for better or for worse, as a frequent flyer, quote unquote. So there are negative attitudes that come with this. And then there's this concept of pseudo addiction, where, the behavioral patterns of someone who has frequent visits, who has poorly controlled vaso-occlusive crises, may mimic someone who actually has addiction, but the individual themselves aren't addicted to the opiates. They just need better pain control. And once you get the pain better controlled, all these other behavioral things that we might attribute to an addict go away, essentially. So it's unfortunate. You can't separate the sociocultural aspects with the management of pain, which is why awareness is important. And this, again, sort of puts it together. This is from the handbook, but again, the lived experience is just striking. And again, I don't need to tell you, you know this better than I do, but again, this is an individual, it was their first time having a crisis as an adult. And this is also, the sociocultural aspects, they affect the pediatric population, but they certainly affect the adult population. This is a young male who finally transitioned into the adult population, and he was in pain. His pain wasn't managed. And, this is striking. One time I was yelling for help. They called security, and security threatened to call cops because I was irate about a lack of care. Now, can you imagine not giving pain medication, to an individual who has an ischemic leg, so a leg that doesn't have blood flow, that you can see it's going white or black, and then threatening the cops on them because they're yelling in pain? In no other disease in healthcare, is this acceptable. So this is the unfortunate roadblock to good treatment of sickle cell disease related pain. Almost done, promise. So this is the last one, the concern about addiction. This is what I want to say. There's no increase in addiction in opiates. I think this concern needs to be put to rest. If anything, the fact that we're treating pain so poorly, patients may look for other avenues to dull or manage their pain. And there is some suggestion in a recent article that showed individuals with poorly controlled sickle cell pain are at a risk of alcohol use disorder, which, this is horrible. But ultimately, this thought that if we give opiates to an individual with pain will cause an addiction, while true in the grand scheme of things of pain management in the specific population of sickle cell patients, it's not been shown to increase the risk of addiction. This is sort of my hospital on a busy day. So these are two other barriers I want to put out there that aren't necessarily in the literature. One is when we're full to the rafters, we're having staffing shortages, when it's a busy department. Again, for pain sometimes gets the boot. It goes down the priority list, and this is an institutional barrier in terms of how busy or not busy our hospitals are, and how what the human resource situation is like with our hospitals. The one over here is, again, this is ER from the movies. This is Hollywood right here. No one would doubt why everyone would drop everything and go and attend to a patient that needs CPR. Like, this is very understandable. So this is a bias. This is an emergency, where someone's suffering silently but suffering nonetheless from pain. It doesn't have the same visual as this. So this is a barrier again for healthcare systems as to why pain may not be treated as well. The pediatric world has specific barriers, and the biggest one, frankly, I mean, they're listed here, but the biggest one, frankly, is people are very hesitant to give opiates to children. And this has nothing to do with sickle cell and so on. This is in any illness. A good example from my own practice: a child with extensive burns, they need fentanyl or morphine, and people are just uncomfortable giving that because they're worried not so much addiction, but more, what if they stop breathing? Are we equipped for that? Places like sick kids that treat children frequently are less reluctant. CHEO, for example, or even in McMaster Children's Hospital. This is just worth mentioning. These aren't necessarily healthcare barriers, but these are barriers that exist nonetheless, which are more inherent to the patient themselves. This isn't blaming the patients; it's just sort of characterized. One is, patients, especially pediatric patients, tend to catastrophize, meaning they're having a pain crisis. And remember when we talked about how pain can be modulated? If you don't have a good coping strategy and you catastrophize, then the experience of the pain can actually get worse. And this can be a barrier in terms of treating the pain, because what you would expect to work isn't necessarily working. And then this concept here of injustice appraisal of pain, which is a very unfortunate thing that happens in children too. I mean, imagine being a 6-8-year-old who's had recurrent crises. There's a relationship of, this isn't fair. Why is this happening to me? And again, this will affect how someone may interact with, not how someone may interact, but how someone may interpret their pain and how easily their pain is managed. These are just sort of inherent things things like cognitive behavior therapy, good follow-up with their healthcare group, and like good social supports help address, but for various reasons that they may not be present. And unfortunately, in an emergency room, they're not easy to address either. So last minute or two is solutions. What can we do? Frankly, the solutions are out there. We just need to implement them. And algorithms that are evidence-based. So this comes from the Ministry of Health and Long-Term Care. They gave an example out of, where was it? Yeah, Children's Hospital, Philadelphia. It's essentially saying you need to have some protocols and you need to attend to the pain within 30 minutes. And the more you protocolize the medications you give, based on, is the pain mild or moderate or severe, the more likely people are going to follow that and give the appropriate medication. So don't leave it up to the individual to decide how much they'll give. Have a protocol, but obviously you can fine tune these protocol if the patient you're seeing needs more. The other thing is guidelines exist. Both of these resources, the clinical handbook and the consensus statement from the Canadian Hematology Association, outline very nicely what's needed to be done and what individuals need to know. The difficulty is, again, if you have negative attitudes towards pain and sickle cell disease, the less likely you are to know about these. And the difficulty is just knowing them and being aware of them. Advocacy groups like SCAGO are important in the overall attitudes and management of pain by practitioners, because again, this helps highlight the biases that are inherent, that are out there, and the limitations that we have in treating it. The fact is, sickle cell pain is not just a leg pain, like I said earlier on. At least for me, anyway, SCAGO was eye-opening in terms of my attitude towards treating the pain. This last thing is a bit more hard. This is sort of wishful thinking, but something like a pain program in a hospital or patient control anesthetic, in research, it's been shown to work really well. It's just the practicality of starting it in an emergency room is a bit more difficult. On the wards, hospitals that have pain teams, patients that have these pumps that they can control themselves and give medications to themselves have been shown to help the patients and help control the pain better. So that's my talk. I'm open to questions. We basically talked about what is pain, specifically to vaso-occlusive crises, how it's assessed in the ED and how we need to change that, how we treat it, and obviously the barriers we're facing as we treat it. That's it. Thank you.
Okay, perfect. I would love to just start off by saying thank you for that presentation. I know that I learned a lot from it, and I can only say the same for the rest of the group as well. That was very informational, starting from what is pain and where it comes from, and kind of delving into sickle cell disease, its barriers and solutions. So for our Q&A session that's going to happen now, I would like to open the floor if anyone has any questions. There are two main ways. First, you can write a question in the chat. And second, you can always raise your hand, which is located in one of the applications below, to ask a question verbally. I can start off. I think ketamine, you've discussed, is a new and upcoming fad of medication, and maybe you can tell us a little bit more about it in the use of children. I know you said there were some hesitancies to using it. How does the major difference, or what's the major difference between its use in adults versus pediatrics?
Actually, in the pediatric world, we love ketamine. So when we use medications to sedate individuals for a broken bone or whatever we need to do, ketamine is the de facto drug that we use in the pediatric population because it's been shown to be safer. So less cardiovascular problems. The only issue is again, and when you see it, it's sort of scary, is the children can salivate a lot and they can have a lot of nausea and vomiting afterwards. So in the context of, I need to give someone a little bit of sedation, I want them to go home, it may just prolong how long they stay there. But for the most part, if you ask the average ER provider, they're probably more comfortable giving ketamine to a child over, let's say, fentanyl, both of which have a role in pain management. And what's also the other nice thing about ketamine is it sedates, so it puts you to sleep. Well, it doesn't sedate, it dissociates. So, to use colloquial words, like the patients look like they're on a trip. Their eyes are sort of staring off into space. At a really high dose, they may fall asleep. They're there, they might interact with you, but they're not themselves. They don't remember any of that. And in children, there are these what are called emergence reactions, or they're almost like hallucinations that someone may have. In children, it's not as much of a concern as, let's say, giving it to a 60 or 70-year-old, where you might cause more distress. So for the most part, actually, in children, ketamine is probably more likely to be used.
Perfect. I'll just keep going because I was writing down notes the whole time because I really enjoyed this presentation. I think you talked about this aspect of a subjective dosage for patients, and you asking patients what works for you. And I think when you talked about the barriers to kind of getting care, you talked about, like racism being one. So if you have like any suggestions for how patients should go about, communicating with their healthcare providers about dosages that might work for them, because as you said, not a lot of people are open to that kind of discourse.
Yeah. It's sad though, right? Because then the patient kind of has to modify how they present themselves in order to get good care. And there, in preparing for this, I was listening to a few podcasts, and there was one that had, he's not young man, like he's sort of my age, a Black male in his 30s, and he was sort of talking about what he does, which is really sad when you think about it, but it sort of works for him. And he even stated, if I show up in my casual wear to a hospital and sweats and whatever, I get treated one way. But if I put on a blazer, put on a dress shirt, quote unquote, clean up and give an impression of, a businessman type thing, I get treated a different way, which is really sad. Like, the fact that you'd have to present yourself a certain way. So that talks to the institutionalized, racism and expectations of how someone presents. It's probably the worst for Black males in their like, late teens, 20s, 30s, because again, there's a certain societal view of, if a Black male who's 25 is showing up and asking for opioids, he's got to be a drug addict. That's sort of the how it got established, why it got established. It's probably decades in the making. But in terms of what can individuals do, so I mean, there is that aspect. How you present yourself, which is sad. I'm not saying go to a barber, get dressed up, and then show up to the emergency like that. That's ridiculous. But it's, I mean, really the onus should be on the healthcare team. But to your point, until the healthcare gets with the message, what do you do? And some of the things would be to say, like, listen, I usually get this dose. I know this is a high dose. Whenever I tell a doctor I get this dose, they get anxious, but I've never stopped breathing, and I usually need even more than that. So it's almost like you acknowledging that the doctor will be uncomfortable with it and telling them, I know you'll be uncomfortable, but trust me, this works. And even for me, so, after I adopted this whole attitude of ask them, give them, and I remember the first time, they said something high, like 6 or 8 milligrams of hydromorphone. And like, I'm like, okay, well, let me give you 2 and then I'll come back in 10 minutes and see. Like, there was still a discomfort in giving that. That's a bridge across. So another thing that you can say is like, okay, listen, if you're not comfortable giving me 8 milligrams this hour, can you at least give me, again, 2 at a time every 10 minutes if I need to. There's that. And then the aspect for the healthcare providers that want to get their team on board. So what I've started doing now is, I would go up to my nurse and say, hey, listen, I've ordered this high dose. I know it's high. This is what works for them. Just give them that dose. So it's I think acknowledging that people are uncomfortable with the doses and just saying, but this works.
Okay, perfect. Thank you. We have a question in the chat from Roxanne, and I can read it out. So she says, I was able to use a PCA pump at Sick Kids, but was shocked knowing the loopholes patients have to go through to access it in adult hospitals. What is the process of getting a PCA pump in an adult hospital?
It depends on the hospital. And like your experience is exactly the experience people go through. I mean, Sick Kids is wonderful. Pediatric hospitals in general are wonderful. Like they go out of their way to treat kids, with respect and try to make the family feel good. There's a level of expertise, but there are, 6 children's hospitals. In fact, the matter is most children are going to present to, or are more likely to present to a community than to a specialized hospital. And even for us, let's say if you present to get a PCA in the ER, I mean, it's, I wouldn't say it's virtually impossible, but it's very, very difficult. The difficulty with it is it's a specialized knowledge, both on the part of the individual ordering it. Like, for example, I wouldn't know how to order a PCA pump. Like, it's not something I do. It's not something I give usually. Usually it's an acute pain service that does this. And these are usually anesthesiologists. So it depends on their availability, and it also depends on the institutionalization of a pain service. So a place like Sunnybrook or UHN is more likely to have that pain service versus, a place 2.5 hours out of Toronto or the GTA. So there's that. And then the actual equipment for a PCA, there's specific cassettes and there's specific instruments that are used that, again, the average nurse in an emergency room may or may not know how to use that. So they're really institutional barriers, and they're not necessarily because we don't want to give PCA to patients. It's because it's just not done frequently. So when I mentioned PCA, I just mentioned that, like, you know, one thing an institution can take on is a PCA program for sickle cell disease, for example. But then again, it comes with its own barriers of monitoring and that sort of stuff. But yeah, I think your experience, Roxanne, in terms of sick kids versus adult is very common.
Thank you for the answer, Dr. She again says thank you as well. We have another question. It says, would you suggest that parents tell the doctors what works with their children as soon as we arrive at the emergency room?
I would. I think you know, most doctors are decent people, and at the end of the day, believe it or not, like most doctors, you know, the first thing we're taught and the first way we think is first do no harm. So we come from that lens. You know, we would rather not do added harm in the attempt to treat something. So that's why there may be some hesitation in terms of giving certain doses or medications. However, if you know something works and it's worked before, for sure, you share that with your team, and then you share it in the context of, hey, listen, this happens so often. You know, we've tried different things. We find this works the best. The difficulty in the adult population, but I'll get back to pediatric, is, you know, a very common phenotype or a very common way of somebody who is drug seeking, and unfortunately that exists, people who just want Percocets and whatever, is they would show up and they tell you, hey, listen, you know, Tylenol doesn't work, Advil doesn't work. It's just this one very specific drug that happens to be a street drug that you can sell too. That's the only thing that works for my vague pain that I can't describe. And there's, you know, over 20, 30 years of exposure to that there's a certain cynicism that's not ingrained, but that's made its way into treatment of pain and individuals that say only this thing works. But in the pediatric population, again, you know, you show up with your child. I think that you're less likely to encounter that. But I think having that open dialogue and saying, listen, this is what works. And especially if you've been treated, let's say at Sick Kids or CHIO or something like that, and say, listen, this is what the, you know, specialist hospitals, you know, use.
Perfect, thank you. Next, I will go to, she just has to open your mic, sorry, ask your question. Yeah.
Sorry, can you hear me?
Yes.
Okay, perfect. So my name is Thea Campbell, and I have been an active social worker here at Sickle, and I live with sickle cell disease myself. So first and foremost, I want to thank you, Dr. Erak, for raising the majority of the issues that are within the healthcare system that we face as patients. For the last 4 weeks, I have been in and out of the hospital myself because I'm expecting. And during my admittance, I was asked questions such as, why are you here? Are you sure you're experiencing sickle cell pain that you're feeling, et cetera, et cetera. Now, I've gone through all these questions before in the past, and they're not welcoming questions, as we all know. But during pregnancy, it's an additional stress that's just really not needed. And so if I didn't know how to advocate for myself and speak to my gyno team about it, I don't know where I would be literally today, because I had them, you know, step in and advocate on my behalf. Now, one of the things that I noticed is when they asked me about the medication that I take to monitor my pain from home, and I have a model for myself that I will start off with Tylenol, especially now during pregnancy, and then I will move my way to morphine slowly. I don't have hydromorphine here. I've always only had the morphine 5 milligrams and then Tylenol. And if I wasn't pregnant, actually, excuse that part, but it depends on the pain level for me. If I feel that if I'm at level 6 out of 10, then I will start combining the two, like 1 tablet of Tylenol and then 1 tablet of morphine. The minute I get to a level of 7 or 8 out of 10, I reach over to emerge. Because at that point, I know myself, I know I cannot handle the pain. And plus being pregnant, I definitely need that support, right?
Yeah.
So when I go into the hospital, I'm asked, what time did you take your medicine, which is totally normal to ask that question. How long ago did you take it? How much did you take? But then when I say to them, I don't do hydromorphine. I know what my body needs and what will help. It's just the IV and the 5 milligram of morphine. I'm still asked questions as, would 2 be okay for you? But I walked in with a 10 out of 10 pain now, because at 8 out of 10, there's no reducing the pain, especially on route to the hospital. Yeah. So, and I've asked before, is hydromorphine okay to even take while being pregnant? Because, you know, the swelling is really bad. You can't walk anymore. You know, the ambulance is now involved, and nobody has really answered me. So my question for you is, what would you recommend in terms of pain medicine outside of the morphine for someone that's being pregnant or someone during pregnancy?
Good questions. So, I mean, it's the one little nugget in there. There was a little bit of optimism in there too, which was, you said, you know, your OB team stepped in and advocated on your behalf. So that's always nice to hear. Like, and this truly, teams that know you and healthcare providers that know you, for any patient, they're likely to advocate on your behalf. The unfortunate thing you're experiencing though is just it's multifactorial. The fact is, when a patient who's pregnant presents for any reason, there's a added level of anxiety, you can say, on the healthcare provider's side, because again, the worry is this because of pregnancy, or when we treat it, are we harming pregnancy? And that's just a fact that most of the healthcare providers live with. And, you know, the more comfortable someone is treating patients who are pregnant, the less, you know, the better that experience for the patient, the less you'll see that hesitancy. So definitely when you present, and especially if you're presenting to a place that may not know you, that may not have an action plan, you know, every time you present will be a different person that sees you, and they'll bring in their own biases and their own way of doing things. And for sure, you know, that whole doctrine of first do no harm, you know, it's like, why are you pregnant and taking morphine? Well, what's going on here? So there's that lack of understanding, unfortunately. But I think in terms of what you can do, I think the other bit of optimism, or the bit of what you said that stood out was the fact that you're doing exactly what a patient with sickle cell should be doing. You have a plan in place, you know your limits, you have ways of treating your pain at home. And then it's sort of what I talked about, that arbitrary line that crosses, or that sort of iceberg. You know, once you pass the level, like you know what you need, and then you need to get it in a hospital. There's a bit of that disconnect on the side of where you're being treated, because again, you're showing up pregnant, requiring opioid medication, and it's just a discomfort there. In terms of what you can give, so 2 IV of morphine it's similar to 5 oral. It's not exactly the same, but it's similar. And I think you just need to have that frank conversation with them, telling them, listen, I've already been taking this, I need a higher dose. And 2, frankly, you know, and again, it comes down to the comfort of the practitioner. Like 2 is a very small dose. Like, again, speaking just for me, I usually start with 4 if the individual's bigger, but you would need to tell them, hey, listen, like 2 doesn't work. I've already been taking 2. I need I need the pain better controlled. As far as hydromorphone and morphine, I mean, they're equivalent. So they're risk in pregnancy, as far as I recall. I think it's similar. Hydromorphone, for whatever reason, in healthcare, it's just people, especially in the last maybe 10, 20 decades of people graduate, people are just more comfortable with it. If you have an older doctor, they'd be more comfortable with morphine. Hydromorphone, maybe in older adults and maybe in some populations, has less side effects because it's more synthetic. So it's supposed to be more selected to the receptors. So that's why, you know, healthcare providers like hydromorphone. But let's say, you know, 5 PO or orally of morphine is the same as 1 orally of hydromorphone, right? So the actual medication you take doesn't matter, it's the dose. So I think for you, continuing to advocate to receive the higher dose, or at least redose the amounts more frequently, is going to be important. But what you're experiencing, to summarize it, is unfortunately when you're pregnant, there's a whole level of anxiety that healthcare providers have. And now you're pregnant, plus taking opiates for the medication for your sickle cell disease that you need. And then that just adds a whole all those barriers and biases, they're more likely to just surface to the top. Last thing I'd say is, if you can have one hospital or one area, you're a social worker, which is great. So even talking to wherever you present, for them to create a care plan for you, that may be something that helps too. So every time you show up, whoever the new person is that sees you, they know this is you. You're not drug seeking. You are pregnant. You do take opioids. Just give her what works. That might be something to advocate for your own behalf too.
Yes, I do have a care plan in place. I'm only with Mount Sinai. Yeah. So that's definitely helpful as well. They do have a special pregnancy program that I follow up with. And I have mentioned to them that 2.5 is not going to work. What I do also find that helps more is through IV, because they've offered it by mouth and it's not fast acting enough because, as you mentioned, the pain, not having, blood flowing into your system, it's ridiculously painful. And so if I'm already taking it from home by mouth, I'm coming to the hospital, for it to just get the, for myself to get the IV, not that I want to, especially carrying a child, because I worry myself too, like how harmful is this to the baby, which is why sometimes I try to avoid and take my own measures in the home. And I've been through this before, so it's helpful to know that they have the knowledge as to, okay, she knows what she needs in terms of medicine wise. So let's just give that to her. And mind you, I've had the professionals work with me, and then I was out within less than 48 hours. But then there's the few that still have a little bit of the lack of knowledge to understand that, okay, this person knows what she needs. Her file is right here, but they're still, I don't know if they're asking questions just to be sure or just because they're just unsure of what's happening. But I appreciate your response for that, and thank you. I will continue to do that. I was just curious to know, like, what would be the best way, if there's other ways to prevent such experiences while being pregnant.
No, I think you advocate on your behalf. And I think it's just the continued communication. And again, this is sort of ridiculous, but when you're in a pain crisis, you're in pain. Your ability to calmly tell someone, hey, listen, I feel like my arm is falling off. The 2.5 you're giving me isn't good. I need this. I mean, it's ridiculous to expect that of you, but the unfortunate bias that's there is, as calm as you can tell them, the better. And unfortunately, it has to do with the individuals you see. I agree with you. IV can feel better. Like overall, probably if you measure a few hours down the road, it's equivalent, but IV feels better because you get that peak sooner, which is why IV, and also the distribution, if you have any issues with absorption, IV would be better. But yeah, it's unfortunate. The other unfortunate part, why, patients, like why some of you may experience redundant questions and questions that make you seem, like, what the hell are they asking me? Is the legalization of healthcare, unfortunately. So again, on this side, you're trying to do no harm, you're trying to treat a patient, but at the same time, you're trying to abide by your own college's requirements, make sure that you don't miss something so you don't get sued. Like, there are all these other non-medical things that go into a healthcare provider's thinking. My camera keeps turning on and off. And they affect why someone may get all these redundant questions. And it's just an unfortunate way of how healthcare in North America is set up. It's the litigious nature of healthcare, and it has nothing to do with you. Sometimes it does, and those are the unfortunate, racist bias moments. But as a whole, if you kind of notice this trend, it may not necessarily have to do with you. It just may have to do with what the expectations are on the healthcare provider. Like, for example, for a nurse to give you an opioid, like, they have to go through a certain checklist of things. And even though the doctor already asked you and it's in the chart the nurse looks at is slightly different. Like, it's the same one, but it's slightly different than the one the doctor looks at. And for them to see the doctor's note, it's an added 5 minutes of going through. So there are these, like, frankly, stupid nuances to the way, healthcare is practiced that may affect the experience you have. And it's just an unfortunate reality of our system.
Thank you kindly.
We have another question from M. Barnett, and they ask, is chronic NSAIDs safe for pain management in patients with sickle cell disease?
So anything that works and also has side effects. Chronic NSAID use is not great, like bottom line. NSAIDs are great anti-inflammatory and they're great anti-pain medications. And there's sort of a ceiling dose after which you're just going to get side effects and no real effect because of the way they work. Chronic use of them for some conditions and for some individuals, depending on your healthcare provider and what your plan is, may be a part of your plan. The older you are, the worse that is for you. Now, there's also this balance of, quality of life and then risks of the medications you use. So if, let's say, your quality of life is just completely affected, you're having recurrent episodes, you're having recurrent difficulty controlling pain, that you're not able to, do your hobbies, do your job, all these sorts of things, then that's why we may put someone on a certain medication or not. And, the world of, let's say, rheumatology, so, patients with like, rheumatoid arthritis, or even patients with, Crohn's disease. There are all the other illnesses where we would put people on medications that affect their immune system, that are, frankly, poisons, but they work. And the reason why someone would choose to go on them for a longer period of time is because the quality of life they have outweighs any of the side effects that they have. With like, Advil or naproxen or Aleve or any of these anti-inflammatories, chronic use is not ideal. So it can affect your kidneys. So it can lead to, kidney failure or kidney dysfunction. It can affect your heart, especially if you have any cardiac issues. But, the biggest thing is it can cause bleeding in your gastrointestinal tract, and cause ulcers in your stomach and that sort of stuff. There are some medications you could take to offset at least the GI risk. But unfortunately, long-term use is not ideal. But again, if you need the long-term use in order to function, that's something between you and your healthcare provider you would discuss and figure out.
Perfect answer, Dr. Erak. The next question we have is, what other medications other than Benadryl help with itchiness when on IV morphine?
So it's going to be all the antihistamines. Actually, in the last, maybe 2 or 3 years, the Allergy Society sort of told us to move away from Benadryl and to use newer generation medications. Benadryl is great because it's cheap, and it's great because it's readily available. It's just, it has a sedating effect, which frankly, if you're in pain, sometimes it's great too. So, and the way morphine works as well is morphine sort of dissociates you. So that's a part of its pain management effect. But Benadryl is fine, but you can use things like Reactine, so cetirizine, Aleve, any of those medications can be used. And let's say if you're entering a crisis and you get itchiness, again, talk to your doctor, but it's something, maybe you could go on 1 week of taking Reactine or something like that, just to sort of give you a background support. Now, if you get really bad rashes and really bad itchiness, sometimes a doctor might prescribe you a steroid, but that's not a common thing that's used.
Perfect, thank you. We have another question in the chat. When you have drug reactions and allergies, it causes a major issue when presenting in the hospital. When what is working, trial and error. What do you do when they won't treat you the way that works?
This is tough. So sometimes on a patient's file, it might say they have an allergy to morphine, for example. And then if you delve into it, you find out it's not really an allergy. It's just when they get morphine, they don't, the person doesn't like the way they feel, or they have a lot of vomiting, in which case that's more of a, an adverse reaction than an allergy. So I think one of the things is being clear with your healthcare team too. Like if it says that you have an allergy to something and you don't have a real allergy. So real allergy would be developing hives, lip or tongue swelling, wheezing, like these are life-threatening things. But if it's just, upset stomach or some nausea, have that discussion with your team to determine, is it a true allergy or is it just a reaction? And realistically, if you're needing to come into hospital several times a year to treat your pain, and morphine works, you can also get your healthcare team to send you to an allergist to get truly tested to see if this is a true allergy. Now, the other thing too is between the opioid medications, morphine is like a natural opiate. Hydromorphone is a synthetic. The cross reactivity sometimes isn't the same. So, if you have really bad reactions to morphine, you may get no reactions to hydromorphone. So sometimes within the same opioid class, you might be switched from one to another. But certainly if you have a drug that works and it's just a negative effect, you know, probably advocate yourself to get that drug, but before you do, get like confirmation from an allergist that, okay, this isn't a real allergy.
Perfect. I think we also have another question in the chat. Are there alternatives to reactin type antihistamines due to allergies instead of Benadryl? This I have to use. Any others?
It's tough. So like I said, Aleve is another one. There are, yeah, Reactin and Aleve are the most readily available over-the-counter ones. Yeah, some individuals, based on the what's it called, the formulation of the drug, may have an allergic reaction to it. Yeah, Aleve is, I forget the drug name here. I'm not doing this. You don't see me Googling it right now. Not Aleve, sorry. Arius, thank you. No, Aleve, you're right. Sorry. I'm saying Aleve. Aleve is not the medication. Oh, come on. There we go. I'm talking about Arius. Is what I meant. Sorry. Not Aleve, Arius. Thank you for correcting. Don't use Aleve for allergies. It's Arius. Or Claritin, for example. Claritin's another one.
Perfect. Thank you for that response. Well, there aren't any more questions in the chat, but I actually have a question as well. So you talked a lot about how people with sickle cell disease often be like silent sufferers in the hospital rooms when dealing with their pain. My question is, are there any other ways to kind of notice that they are experiencing that 9 out of 10 pain visually, other or healthcare providers and others as well?
Oh, I think you know, through awareness, I think just healthcare providers need to know that just by definition, and this is what the clinical guidebook says when they say if somebody with a vaso-occlusive crisis shows up to the emergency room, put them as a CTAS-2, right? Like regardless of what they tell you, they're a CTAS-2. I think the healthcare providers need to have awareness that just by definition, by showing up to the emergency room with a vaso-occlusive crisis, it means this individual is in a lot of pain. Regardless of how they present, it means that they're in a sort of what we talked about earlier. If you're showing up to the emergency room, it means you need emergency room level of care. So I think that it's just that awareness that healthcare providers need to just sort of reorient their thinking of the fact that they're here means that the pain is high. We need to treat the pain. And that's what the guidelines say. They say within 30 minutes, some sort of pain assessment and management. And as soon as they show up, they get a rating of a 2. And 2 actually says somebody needs to be seen within 30 minutes.
Thank you for answering that question. I don't see any more questions in the chat, so I'll just open the floor up one more time for any additional questions that anyone has. If not, we can proceed to wrapping up our session today. Questions. I would like to also say if there are any other additional questions to come up after, please feel free to email me at education@sicklecellnemia.ca, and hopefully I can forward those to Dr. Erak and give you a response about any of the other questions, additional questions that you have. Okay, perfect. Again, I just want to extend my thanks and appreciation to Dr. Marko Erak today for educating us on pain assessment and management for pediatrics and adults with sickle cell disease. We all learned a lot, and I can definitely, echo everything. And as you can see in the chat, echo a lot of what was being heard, what was being learned and taught today. I just want to, again, put a disclaimer out there. So remember that the information shared today does not constitute medical advice and is shared with you for information purposes only. No material shared with you are intended to be a substitute for professional medical advice, diagnosis, or treatment. Always ask your physician or other qualified healthcare providers with any questions you may have regarding a medical condition or treatment before undertaking a new healthcare regimen. Please do not disregard advice or delay seeking it because of something said during this webinar. additional things, well, because you guys are all here, I would like to give you a sneak peek to our next session next month, which I will quickly share with you guys. If you find it, we will be discussing hydroxyurea use in sickle cell disease with the having a physician, parent, and patient perspective or adult perspective there to give you all the information you need on this intervention in sickle cell disease. Just now, with that being said, we'll be done with this webinar. Thank you again. Bye for now.